So firstly, I would love to make an opening speech right over here. And good evening, good afternoon, good morning, everyone. This is Jack from Wisonic Medical. Welcome to join this global webinar of Wisonic Dandelion College. And this platform for sharing and learning more about the latest research and expertise of regional anesthesia, pain management, and intensive care. Today, it is really our great honor to invite Dr. Axel Sauter to be here as our speaker. He is one of the top experts in the field of regional anesthesia safety research in the world. And Dr. Shuai Tang from China will be our moderator to introduce Dr. Axel Sauter. Dr. Shuai Tang is a medical doctor and associate professor of anesthesiology in Peking Union Medical College, Shuai University. Currently, he is the chief of regional anesthesia subdivision at the Department of Anesthesiology in Peking Union Medical College Hospital. He is a member and secretary of Regional Anesthesia Committee of Chinese Society of Anesthesiology. Dr. Shuai Tang is a very young and very enthusiastic scholar in regional anesthesia and published many peer-reviewed articles in anesthesiology. So let's welcome Dr. Shuai Tang.
Hello, everyone. Hello, dear guests from all over the world. Today, we have the honor to invite Dr. Axel Sauter to give us a speech about techniques to improve safety in regional anesthesia. And first, please allow me to introduce Dr. Axel Sauter. He has been working clinically in the field of anesthesiology in Norway as a physician in anesthesia since 1999. After accomplishing his PhD program in 2009, he has been employed as consultant anesthetist at the Oslo University Hospital in Norway. Since then, a main focus of his work has been acute pain therapy, regional anesthesia, and orthopedic anesthesia. From 2015 to 2018, he has been working clinically as a consultant at the Inselspital University Hospital in Bern, Switzerland. From autumn 2018, he is continuing his clinical work and research position at Oslo University Hospital. His scientific focus is also in the field of regional anesthesia and innovative technologies. Today, he is going to share us the topic of techniques to improve safety in regional anesthesia. Let's welcome Dr. Axel Sauter.
Thank you very much for this kind introduction. Hello, everybody. I'm very excited. This is my first presentation in China, even though I'm sitting in Oslo physically in these Corona times. But I'm looking forward to be with you for the next 1.5 hours. And I hope you will have some interest in the topic, safety in regional anesthesia. Thank you for being here.
Okay, so shall we start?
Yes, we can start.
Hello, everybody. I'm happy to be here today. My name is Axel Sauter. I'm working as a consultant at the University Hospital in Oslo, Norway. I'm going to give a talk on techniques to improve safety in regional anesthesia. I have two competing interests that are relevant for this presentation. I have a pending patent application for a multiple frequency impedance method to determine biological tissue and to detect intraneural needle placement. And I'm presenting results from a study that was done in cooperation with B. Brown and Phillips that has received funding from the European Union as a Horizon 2020 project. There's so much to say about regional anesthesia and safety that I have to narrow down this topic for my presentation. I will exclusively or mostly talk about safety in peripheral nerve blocks, and I will not talk about safety for epidurals or spinal anesthesia. Anyhow, I want to mention these two studies of Cook and colleagues from Britain and Moen and colleagues from Sweden. They were published in 2004 and 2009, and they showed quite a high incidence of serious complications related to neuroaxial blocks. And after having read these results, me and my colleagues, we even less frequently used epidurals and tried to replace them with more peripheral regional anesthesia techniques. The photograph shows the participants of our last regional anesthesia workshop at the Oslo University Hospital. Everybody's pretty much excited, but I'm a little worried that some of the participants might forget that there's quite some risk associated to these techniques that we teach, even though we use ultrasound and everything seems easy and completely safe. The following talk will be about these risks and risk factors and safety measures that we should provide to perform successful regional anesthesia. Some of the threats we face when performing regional anesthesia or peripheral nerve block techniques are infection, bleeding, local anesthetic toxicity, nerve injury, or damage of organs that are close by our target structures. As I mentioned before, I have to narrow down the topic. I will not talk about bleeding associated to nerve block procedures, and I won't talk about local anesthetic toxicity. I will focus on the incidence of nerve injuries and how to avoid them, about collateral damages, that means damages of other organ structures that are close to our target nerves, and a little bit on the incidence of infections. And as I said before, even though we use ultrasound, everything seems simple and we try to have control of our needle. We can see the injectate and we can see the target structures. We still see those complications. And some of them, nerve injuries, they have not decreased after we started to use ultrasound as a gold standard for regional anesthesia. When talking about safety, I would like to start with standard monitoring. I would expect that most of you would agree that we should provide an ECG, oxygenation measurement and blood pressure measurements before we start with a block procedure, and that our patient should have an IV cannula in case we need to provide IV medications due to some side effects or just for the matter of sedation during a block procedure. As I mentioned in the beginning, we might be worried to get an infection when performing regional anesthesia techniques, when putting in a needle or catheter in our patients. And actually the incidence of such infections when it comes to catheter placement is quite high. After 48 hours, in more than 50% of our patients, we will find some bacterial colonization. And you see these on the list on the left-hand side from a study of Covillon and colleagues. There are risk factors associated to such infections and stay in an intensive care unit, the duration of catheter use, absence of antibiotic prophylaxis, the axillary or femoral localization, and frequent changing of dressing are one of these factors, as shown by Capdevila and colleagues. Luckily, those infections or those colonizations are very seldom serious, and the incidence of an abscess formation is less than 1%, probably very much lower. What we usually see is a local inflammation or local infection in some of our patients. So also in my experience, it is extremely sheldon that we see a patient that really has to be treated due to an infection associated to our nerve block techniques. However, we have to follow up, and one important rule is maybe not to leave catheters too long in the patients, to remove them as soon as possible. An important question is about sterility precautions when performing peripheral nerve block procedures. And there's of course a difference between single injection techniques or the placement of catheters. And the data I want to show you is from a nationwide survey that we performed in Switzerland. Anesthesiologists were asked about their habits when performing regional anesthesia or peripheral nerve block techniques. And to explain the figure, when the bars are white, this means that a colleague would always proceed in a certain manner. When it's getting darker, it means often, seldom, or never. The black bars mean that a colleague would never proceed in a specific manner as asked in the survey. And this study was performed at the Inselspital, the University Hospital in Bern in Switzerland. As you can see on the left-hand side, most Swiss anesthesiologists would use sterile gloves when performing single injection techniques. They would also use sterile operation drapes and sterile ultrasound covers. And on the right-hand side, and this is not so surprising, the numbers are even higher, so almost 100% would go for sterile gloves, sterile operation drapes, and ultrasound covers. A high fraction of the Swiss anesthesiologists would even use a sterile coat when placing a peripheral nerve block catheter. These data do not show what is the correct way to provide sterility precaution for a nerve block procedure, but it gives an insight on what many of us think is appropriate to reduce the risk of infections. I will proceed with nerve damage as a possible complication after a peripheral nerve block procedure. How risky is it to perform a nerve block? How high is the incidence? And we have to distinguish between transient neuropathias, where a patient might have an irritation of a nerve that lasts for days, weeks, or even months, but that will resolve without intervention. And this might be like a patient experience paresthesia, altered sensation, or even pain for a while. And as the data from Brull and colleagues suggest, there is a difference in the incidence depending on which nerve we block. Interscalene might be the highest chance for such transient neuropathias, almost 3%, while other nerves like the brachial plexus or the peripheral nerves of the brachial plexus might be more robust, or the sciatic nerve in the popliteal area. It's much harder to harm compared to these proximal nerves in the interscalene region. Of course, we are even more worried to provide a permanent nerve damage to a patient, and the incidence of these permanent nerve damages, according to the data of Barrington, is around 0.4 per 1,000 blocks. So it is not too frequently, but it's not that sheldon that any colleague performing a lot of blocks is at risk to experience such a complication in one or several patients. These data are from an area before ultrasound was regularly used as a gold standard as today, and we could expect that the numbers have decreased, but new data actually suggests that the incidence of nerve damage or transient neuropathy has rather been increasing after we have started to use ultrasound. And we can only speculate why this is so. Some colleagues, they would suggest that there are more anesthesiologists performing regional anesthesia with ultrasound compared to the time where only nerve stimulation was available, and that many of these colleagues are not adequately trained to perform nerve blocks in a safe way. Another explanation might be that while using ultrasound and while having the possibility to see our nerves and see the needle and the needle tip, we are encouraged to go closer to the nerve, and that we even want to provide several attempts to the nerve to obtain an optimal local anesthetic distribution around our target nerves, so that we are unwillingly getting more aggressive towards the barrier of the nerve compared to when we were using nerve stimulation in former days. We have to distinguish between the mechanisms for nerve damage, and we can see toxicity. Local anesthetics are nerve toxic, and some adjuvants can also be so. There is a mechanical nerve damage that we go with the needle into the nerve and destroy some of the vital structures. There might be ischemic mechanisms for nerve damage. We might interact with small vessels supplying the nerve with nutrition and oxygen, and what is always stated as an important factor is that a high injection pressure, that we forcefully inject the local anesthetic into the nerve, might disrupt the axons. Depending on what happens within the nerve, we end up with a transient neuropathy or with a permanent nerve damage. And it's a difference if only the axons are damaged and we have an intact nerve sheath, or if the sheath and the axons are disrupted. And in such a case, there is not much hope that there will be restitution for a damaged nerve, as you can see on the left-hand side of my slide. Traumatic needle-to-nerve contact might lead to nerve damage. And there's a difference in how far we advance the needle to the vulnerable structures. If the needle is only in touch with the nerve, we might end up with paresthesia, probably not more. If it passes the epineurium, the outer layer of the nerve, it might be more troublesome, but we are actually most worried that the needle gets into with the perineurium numbered with 1 on this nice figure of Anakin and colleagues. And when we put the needle tip into the axons, and in worst case, if we even inject towards the axons and build up a high pressure, this might be associated with the highest chance to end up with a nerve damage when performing a peripheral nerve block procedure. What should we do to avoid damage of a peripheral nerve? Most obvious would be to avoid direct contact of the needle tip and the nerve. And you might ask, is this possible? Can we still obtain successful blocks when our needle tip is in a remote distance to a target nerve? And I want to show you this very exciting study of Eric Albrecht and colleagues. and he performed an up-down sequence where he variated the distance between needle tip and nerve to calculate an effective needle to nerve distance for an ultrasound guided interscalene block. So what they did, they started close to the nerve, 0 millimeter distance to the nerve. They did their local anesthetic injection, and when there was a successful block, they reduced the needle to nerve distance. When there was an unsuccessful block, and you see it on the figure on the right hand side, failures are marked with black dots. They decreased the distance, and in this way they could calculate that the maximum effective needle to nerve distance, where 50% of the blocks would be still successful, would be 8.3 millimeters for an interscalene block, and to obtain a 95% success rate, the needle could still be in distance but closer 1.6 millimeter to the target nerves. I think this study is amazing. Of course, you can consider that you would need or will need a higher volume when you decide to inject from a wider distance. And I'm also not sure if this data is transferable to other block techniques. So the optimal or the maximum effective needle to nerve distance will of course vary in different anatomical locations. As we sometimes have to get closer to the nerve and closer to the target nerve, as suggested by Albrecht and colleagues in their interscalene study, we want to increase safety and reduce the risk for nerve damage as much as possible. In Norway, all my colleagues will use ultrasound as their primary guidance for a peripheral nerve block, but then there is a discussion, should we use nerve stimulation in addition? And here we are talking about dual guidance, and the theory is that with a minimal threshold, a minimal current setting, we will get a neuromuscular response when the needle tip is too close to the nerve or when it has passed the epineurium as the outer barrier of a peripheral nerve. There are many studies, lots of them performed in animal models, some clinical studies, and as a result, all these studies show with a low current threshold, the chance for an intraneural or intraepidural needle placement is quite high. However, there is no real consensus on how low this current threshold should be to be on the safe side to avoid traumatic nerve contact. And thresholds between 0.2 and 0.5 have been suggested according to the data of many of these studies. Not everybody is using dual guidance as a standard method for peripheral nerve blocks. And when you ask colleagues in different countries, when I ask my colleagues in Britain, Ireland, Norway, or Switzerland, they will come with different answers. In Norway, it seems dual guidance is not that popular compared to Switzerland, where more than 50% of the colleagues would use ultrasound and nerve stimulation in combination on a regular basis. When it comes to the current setting, I just mentioned that studies suggested some values between 0.2, 0.5. Most colleagues would use a current setting between 0.3 and 0.5, and they would feel that they are on the safe side and that they can avoid too close or too traumatic contact between the needle tip and the nerve. There's an ongoing debate regarding the adequate current setting that should be used to avoid a traumatic needle-to-nerve contact. There are many colleagues that would consider a current setting of 0.5 as too low. What I want to show you in this figure is a comparison between different needles. This is unpublished data from Thorsten Steinfeld and colleagues in Marburg in Germany. And what you can see is that probably due to a different needle tip geometry, maybe due to a variation in the insulation of the needle, that the incidence of the frequency of successful stimulation varies when using different current settings with these 3 needles. So it is apparently wrong to say that one minimal current setting is the correct one. We have to relate this to the specific needle type, and we can be quite sure, and we did some studies in the past that could show that the ability to stimulate a peripheral nerve varies between different anatomical location and different peripheral nerves. So there is not one true current setting. We have been talking about dual guidance, about the simultaneous use of ultrasound and nerve stimulation. Some colleagues would advocate the use of pressure monitoring during nerve block procedure to reduce the risk of nerve damage. The initial studies were performed in animal models, and what was found is that when inserting a needle into a nerve and generating an injection pressure higher than 15 pounds per square inch, it was associated with a extremely high risk that the needle was within the perineurium, right within the axons in the peripheral nerve, while lower injection pressures were associated with the needle position outside of the axon bundles, outside the perineurium. So this would indicate that high injection pressures are associated with a higher risk to harm the vital structures of the nerve. The situation is nicely illustrated on this figure from the Nicora website. You can see that the needle tip is beyond the perineurium, within the axons, and in such a situation we would expect a high injection pressure above 15 psi, and we would of course immediately stop injecting when our pressure monitor shows such high pressure. What I think is problematic with the figure are the dimensions. I think the figure rather reflects the situation from the previous animal experiments, where a very tiny needle was placed with a microscope into the nerve, and this needle was indeed so small that it could fit within the perineurium. But when you have a look on the right hand side, and this is just to illustrate the size of a common needle, 21 gauge, 18 gauge, in relation to an average nerve fascicle around 800 micrometers, and you can see it is impossible to place such a big needle into a tiny fascicle. If you're not convinced by my schematical figure to illustrate the relation in size between the block needle and the peripheral nerve fascicle, you might want to have a look on this wonderful electron microscopical image from the textbook of Admir Hadjik. And you can see that the fascicle, marked with a red circle, is much too small to place a block needle inside. Those who advocate pressure monitoring I think most colleagues, they would not expect anymore that the needle is physically placed in one fascicle. They rather would think that there are areas with tight connections between fascicles, and that it is harmful to inject with a high injection pressure towards these areas within the cross-section of a nerve. If you're curious to know what the Swiss colleagues do, have a look on this figure. Most Swiss anesthesiologists, they do not use pressure monitoring. As before, there is probably a difference between countries and regions, and I think in Belgium, for example, the pressure monitoring is much more common compared to Switzerland, or talking about Norway compared to the Scandinavian countries. I briefly want to mention another method that has been developed to identify traumatic needle-to-nerve contact. Hendricks and colleague, they equipped a block needle with a light source and a detector, and by analyzing the results from optical spectroscopy, they could discriminate fascicular nerve tissue from the surrounding tissues with a sensitivity and specificity around 90%. To my knowledge, the method has not been further developed for regional anesthesia use, but there might be other medical implementations where the method can be used in the future. As I told you in the beginning of my presentation, I have a personal interest in the use of bioimpedance to discriminate tissue types. I first want to show you two studies, one from Tsui et al. In an animal model, and the study of Bardou and colleagues in human clinical studies. They both were comparing intra with extra neural needle positions and comparing the measured impedance in these needle positions. You can probably see it best on the right-hand side. Bardou and colleagues, they were comparing impedance measurements when accidentally placing the needle within a nerve with no nerve punctures. And you can see there is a significant difference between the measurement in both groups, but there's also a huge overlap in the boxes, so the method will not be so precise when using it as in a device to avoid intraneural needle placements. A limitation of the studies that I just showed you is that both groups used the square pulse of a nerve stimulator to measure or estimate impedance. However, impedance is a little bit more complicated. It relies on an alternating current, and depending on the frequency that is used, you will obtain different results. Also, impedance, in contrast to resistance, always consists in a pair of numbers. So each measurement with the defined measurement frequency will end up with a pair of measurements giving a complex number. So you will have a magnitude and a phase angle, and these together define the impedance measurement. I want to show you the results from our study that we performed in Oslo and published in 2016, where we compared different needle positions in a pig model. We compared intraneural with muscular with subcutaneous fat. And as I told you before, we're talking about a pair of numbers. On the left-hand side, we measure the modulus, and on the right-hand side, we measure the phase angles, and then we use different frequencies. So from left to right, all the dots represent one measurement with an increased frequency up to 300 kilohertz. And what you can see, that there are differences in the magnitude, but there are also differences in the curve shapes. And you can see this especially on the right-hand side with the phase angle. So when we tried to use our measurements to identify tissue types, we were not so interested in the change in the absolute values, rather in the change of the curve shape. And by analyzing the frequency-dependent curve shapes of the modulus and the phase angle, we tried to build an algorithm that could help us to identify the tissue types. So we used the curve shapes, the specific curve shapes, as a kind of a fingerprint for intraneural, muscular, or subcutaneous fat needle positions. When we plot our data in a receiver operating curve, we get an area under the curve of 97%, indicating very high specificity and sensitivity for this method. And you can see our data, the red curve, while the data of Baudu et al. Were only one measurement with the square pulse of the nerve stimulator was used, is much lower. We used the data and the algorithm that we developed in the animal study to simulate a device interface that could be used to avoid intraneural needle positions. You can see measurements related to different measurement frequencies, modulus and phase angle, and the delta of a phase angle. And below the C value, this is actually the result of our algorithm. Each time when C drops below 1, this is set as a cutoff, we estimate intraneural needle positions, and the indicator will turn from green to red. On the ultrasound image, you see the needle that is advanced towards the sciatic nerve in one of the test animals, and when the needle tip passes the epineurium, the indicator color turns from green to red. We conducted one more study with the method. This was done in healthy volunteers, and in contrast to the animal study before, we did not want to puncture the nerves of the volunteers. Instead, we did needle-to-nerve contact and tried to press the electrode area as tight as possible on the nerve. By doing so, our results have not been that impressive as before. You can see it, the area under the curve is lower, as in the study I just showed you, and this actually means that the method is most suitable to identify tissues that completely surround the needle tip. Hence, an alarm for a needle-to-nerve contact will be most sensitive and specific when the needle already has passed the epineurium. We are very motivated to develop this method further so that it can be used in a not too far future in our clinical practice. There are a lot of challenges. We try to design an optimal needle for impedance measurements during regional anesthesia procedures, and we also try to develop a suitable device that can be easily used in our clinical practice. I've been focusing on nerve damage and measures that can be taken to avoid such complications, but there are other threats and what I call collateral damage, the risk to puncture other organs, vital structures that are close by our nerves that we want to anesthetize. The image is from a case report of Koskøljak Nielsen and colleagues in Copenhagen in Denmark, and this was a pneumothorax, and it occurred during an infraclavicular block, and this block was done by the aid of ultrasound guidance. What can we do to reduce the risk of such collateral damages? We do not want to puncture the lung or vessels or vital organs. Well, most of all, it is important to have control over the needle, and we have to be able to visualize the needle and the needle tip all the time. And there are some helpful technologies. Modern block needles, they are often ultrasound coated. They give a better reflection, and they are much more easy to visualize and identify in the ultrasound image as seen above. And there are also software settings in modern ultrasound machines that makes it easier to visualize and enhance the needle visibility during a block procedure. There is a variety of needle tracking systems that can be used to improve needle control. Some of them use an electromagnetic field, there are optical systems, there are mechanical devices. All of them potentially might facilitate the identification and visualization of the needle during an ultrasound-guided block procedure. The video clip shows an electromagnetic needle tracking system, as it is part of many of the Wisonic ultrasound machines. Magnetized needles are used and can be detected by the technology, and on the screen you can see the pathway of the needle, the green stripes, and the level on which the needle will pass through the ultrasound plane by the red square. Needle tracking systems seem to be particularly useful in a teaching situation with unexperienced colleagues. This is a nice learning curve study by McWeiser and colleagues, and as you can see, the COSAM scores are improving significantly in the group of students using GPS tracking systems when performing their first block procedures. I have been involved in the development and testing of another needle tip tracking technology. This is the OnVision system by B. Brown and Phillips. For this technology, needles are used with an integrated piezoelectric sensor at the tip of the needle. This is marked with the arrow on the left-hand side of the figure. The sensor can pick up ultrasound waves that are transmitted by the ultrasound transducer, and by an integrated software, the signal can be processed and the exact position of the needle tip can be indicated in an ultrasound image. And the needle tip position is then indicated by a green circle. If the needle tip is a little bit outside of the ultrasound beam, the sensor can still pick up a faint signal, and instead a red circle will be used with increasing diameter to indicate the position of the needle tip. The video clip shows an out-of-plane lumbar plexus procedure with the needle tip tracking technology. And here we can see an infraclavicular block, an in-plane procedure with needle tip tracking. We performed several studies to test the needle tip tracking technology. The first study was done in a phantom model. 40 anesthesiologists at Oslo University Hospital performed in and out of plane procedures with and without the help of the needle tip tracking technology. Our main outcome measure was performance time. In addition, we performed hand motion analysis as a measure of the precision of the procedure. What we could see is that for out-of-plane procedures, performance time was significantly reduced with the needle tip tracking technology, and the number of hand movements decreased. For in-plane procedures, there was a tendency but no significant difference in favor of needle tip tracking technology. We conducted 2 studies with healthy volunteers. Both studies had a crossover setup. That means the participants received 2 block procedures, one with and one without needle tip tracking. The sequence was randomized. The data here is for a study in out-of-plane lumbar plexus block procedures, and you can see that the number of hand movements and the path lengths measured by hand movement analysis decreased significantly when using needle tip tracking. Procedure time, our main outcome, was reduced, but the p-value was on 0.1. But as such a study has an explorative character, it gives a good indication that the technology can improve block performance. We performed another study that is not yet published. This was in an in-plane infraclavicular plexus procedure, and for the in-plane procedures we did not see improved results with needle tip tracking. So what we concluded is that, as seen in the phantom model, the method might be most helpful for out-of-plane procedures. This is not so surprising. Most people have problems to identify the needle tip in out-of-plane procedures. And we also considered there was a big limitation of our study, and this was that the doctors performing the blocks, they were all highly experienced. And as seen in the study of McWeiser, novices in the teaching situation might have more benefit with a technology, a tracking technology, compared to experts when performing block procedures. In my presentation, I have introduced several technologies that can be used to improve safety during regional anesthesia procedures. However, I must say there is no good evidence that we really can use complication rates by using pressure monitoring, dual guidance, needle tracking, or impedance. It is more a matter of common sense and at the end, a personal decision if we want to adapt these technologies. And another question is, of course, should we use one or several techniques in combination? And I must admit, at the end of my lecture, I have no good answer for this. As I mentioned in the beginning of my presentation, there is not even strong evidence that can prove that ultrasound guidance reduces the number of complications. What about those new methods that potentially improve safety during nerve block procedures, which one should we choose? I think we have to use common sense. We have to pick those technologies that we feel can improve our clinical practice and that we feel comfortable. I hope that there will be good studies in the future that can prove that some of these techniques improve safety. Thank you very much for joining my presentation. I hope to see you soon somewhere on a conference.
Okay, thank you, Dr. Axel Sauter. It's very wonderful.
I guess there might be some questions.
Yeah, we can see some questions here on the board. Okay, let's pick some. Okay, the first one, audiences asked, should we only use dual guidance or should we even combine more technologies to do regional anesthesia? For example, ultrasound, electrical nerve stimulation, or pressure monitoring?
That's a very good question. And if you ask different colleagues, you will get different answers. Theoretically, you can improve safety even more when you use several methods. But you must think about that there are positive results from these technologies. You might get a neuromuscular response quite early, and there might be high pressure while using pressure monitoring. And when you get too many methods together, in my point of view, this can get confusing, and it might rather disturb your workflow, and you will not be able to get a nice, smooth procedure in the same way because you're looking on too many devices at the same time. So I think one has to reduce and certainly not use more than 2 or 3 of those technologies in combination when it shall lead to a success.
Okay, sure. And the second one, would you recommend to use dual guidance for a TAP block, the TAP block, TAP block?
Yeah, that's important because I implicit was talking about perineural block procedures where the needle is really advanced towards a nerve. And when you perform these fascia plane blocks like the TAP block or the quadratus lumborum block or the erector spinae plane block, you're far away from the nerves. So you will not need nerve stimulation. And one can discuss if pressure monitoring could help you to identify the right plane. I would say that ultrasound gives you a lot of information that can be sufficient to successfully and safely perform a fascia plane block as the TAP block.
Okay, as you mentioned, the lumborum quadratus block, how do you like it? Do you feel it's stable for the block effect?
Well, it depends on which quadratus lumborum block you're talking about,
okay,
and what effect you're seeking. Because some of the quadratus lumborum blocks, as the transmuscular, they aim for a paravertebral thoracic spread. But at the same time, these blocks are used for hip surgery. There are several studies or case series that would recommend a transmuscular quadratus lumborum block for lower limb surgery. And I think this is quite complicated, and it depends a lot where the needle tip ends up in relation to the facial layers. When it comes to the classical quadratus lumborum block, the QL1 or the lateral quadratus lumborum block, and when you are aiming for a direct anesthesia of the abdominal wall below the umbilicus, I think this is a very reliable block.
Okay.
And when it comes to far spread, this might not be the same in each patient.
Okay. Next question. What safety measures do you use in department when you perform peripheral nerve blocks? I think this question means your routine daily
Yeah,
measures.
but we're maybe not talking about the fascia plane blocks, but the nerve blocks where the needle is advanced directly to a peripheral nerve. And as I said before, and as I showed you the data from Switzerland, and I told you that in Norway it's not as popular. It depends a lot on your working environment. In Switzerland, I would have used the nerve stimulator more frequently because it is part of the culture. In my hospital, we use dual guidance frequently, especially when it comes to complicated and deep block procedures. When it comes to something that we consider as a simple block where we have a good view of the needle, here we would only use ultrasound. But I cannot give this as an official recommendation. I don't know what the situation in China would be.
I think it tends to be ultrasound guided, and we would use a nerve stimulator less and less. Just maybe only for sometimes we do the teaching job. We will tell the students how the nerves work when it's stimulated, and or some deep blocks, for example, lumbar plexus block. We will, and the sciatic nerve block, because they're deep. We would prefer the dual guidance, but we don't have the monitoring of the injection pressure commercially. We don't have it. Do you have that in your on the market?
I think it's not on the market in Norway, but we could certainly obtain it from Central Europe. But when you're talking about the lumbar plexus blocks, this is also an example where I always would use nerve stimulation. And one side, I do not want to see a nerve response with a low current because I don't want to get too close to the nerves. On the other hand side, this is such a deep block, and I frequently like to elicit a nerve response with a higher current just to verify my ultrasound finding.
Because the ultrasound means the anatomical location, and the electrical stimulation means the functional location.
That's right.
And we would move on. The next question. Do you think we should perform blocks in anesthetized patients?
That's also a tricky question. And I must say, we do it a lot in our hospital, but this is mainly because we have a lot of children. And I think in children, it is wise to have the child rather anesthetized, so it does not move during the procedure. So it is less risky to have control over the situation. When it comes to adults, it was in many years a golden rule that you never should perform blocks in anesthetized patients. But it weakens a little bit up, and when you talk to colleagues, more and more anesthesiologists, they would, at least if there's a good indication, also perform blocks in sleeping patients. I think it should be a good reason to do so. A very anxious patient, of course, would be a reason, or maybe even that in a treatment, it is most appropriate to do it while the patient already sleeps. But then I would definitely go for dual guidance, because the reason I'm worried that my patient is sleeping is because he cannot talk about paresthesia. So when I'm too close to the nerve or in the nerve, he cannot tell me because he does not feel pain anymore. So I want to have some other devices that improve safety. So at least a nerve stimulator with a minimal current setting.
And do Europeans complain a lot about the nerve stimulator when they are awake?
I think it depends on who's doing it and how extensive you use the nerve stimulator. So you don't have to use it all the time. But of course, people like it more when they don't have these strange muscle movements and these strange feelings. But I think most patients accept it.
Okay, yeah, I think in Chinese, for Chinese, many people will accept it if you communicate a lot, have a good communication before the blocks. They can tolerate it very well. Okay, next one. Do you always elicit a neuromuscular response when performing a peripheral nerve block?
No, when I use dual guidance, I usually do not want to elicit a response. Usually, at least in the superficial blocks, I want to see a good local anesthetic spread around the nerves that I have clearly identified. So I do not need a response to prove my needle position. But it might be different in the deep block with an obese patient where the nerve is not so clear. Then I actually would like to see some movements of the muscles that are involved in or that are belonging to the nerve.
Mm-hmm. Yeah. Next one. What is the best needle tracking technique?
And I cannot give an answer on this because there are no studies that are comparing needle tracking methods. So as our studies, we only compared ultrasound with needle tip tracking to ultrasound without. And there are even not many studies in humans. I think we did the only randomized control studies in a human setup, at least in regional anesthesia when it comes to needle tracking. I think you always have to think about the cost and the workflow. So every method that is easy to use and that does not give a high bill to your department can be worth to try. Other methods that are complicated, where you have to install sensors into the needle, that might take a lot of time, I would be a little doubtful.
Sure. And next one, I have a problem confused me during regional anesthesia blocks. The needle body is not enough clearly when I'm doing a puncture. How to solve it?
I'm not sure if I understood the needle, the image.
Yeah, I think this doctor cannot see the needle, the trajectory of the needle on the ultrasound screen, and how should he or she solve it?
I think the first thing is to be patient and just take the time consequently to see the needle before advancing any further. And so things will be better and better each time you consequently try to follow your needle. And then you do not necessarily have to invest in a needle tracking technology. It also helps if you have good needles that have an ultrasound coating, and it's of course much easier to identify the needle when you have these structures implemented on the surface of the needle and you get this bright signal even with a very steep insertion angle.
Okay, yeah. And next one, what drug and how much dose you prefer in tap block?
Also a good question. In regional anesthesia and anesthesia, we have been skeptical using bupivacaine because of the cardiac problems. So we use ropivacaine. We have been using ropivacaine a lot, but I frequently started to cautiously use low concentrations of bupivacaine because I think, even though I don't have data for the top block, that you can get some extra hours, especially when combining it with epinephrine as an adjuvant. But you have to be aware that bupivacaine is probably more cardiotoxic compared to ropivacaine. So you have to be extra cautious with monitoring, with repeated aspirations, and really be able to visualize the spread.
And what's the concentration of ropivacaine?
It would be 2.5 or lower.
2.5 or lower.
Diluted 50-50 So
Okay.
you will still have a good effect.
Okay. And how long will it act in patients?
A good question, and there are some studies that have investigated the effect, and most of them go for the analgesic effect. Probably you will see a decrease in pain the first 12 hours, if you're lucky, even a little bit longer.
Okay.
In my point of view, there are some studies that have compared tap blocks with quadratus lumborum blocks, but probably you will have a longer lasting effect with some of the quadratus lumborum blocks compared to a tap block.
And
so
do you put some
at least 24 hours. There are some studies where they showed effect lasting 48 hours, but I think these are studies that should be repeated and confirmed.
Yeah. And generally, would you prefer to put some adjuvants into the local anesthetic, for example, dexamethasone, dexmedetomidine, or other medications?
I think there's good evidence for dexamethasone, but it seems like it's not necessary to give it as an adjuvant with the block. You can give it parallel in the IV route, and you will still get almost the same extension of the effect. In our department, clonidine is quite common as an adjuvant. Dexmedetomidine might be as good, but there are some studies that show that there is a more extensive sedation. So if you perform blocks in day surgery patient and you want to send them home quickly, dexmedetomidine might not be the best choice. Clonidine is probably not as strong.
Okay. And do you think the timing of administering the dexamethasone intravenously is important? I mean, when you just giving the you have to give the dexamethasone intravenously as you inject the local anesthetic perineural.
I know colleagues that are working on studies to investigate this. I don't think they have published yet. We only can speculate. I just as a gut feeling, I would do it quite close.
Okay.
Not too far distance, but we do not know yet.
Okay. And next question, and maybe that's the last question. If the patient will have a laparoscopic surgery, what nerve block method is better?
I could say an epidural might be best, but we do not want to put epidurals too much in patients. So it certainly depends on how much pain do you expect. And when it's a big trauma, I still would go for the epidural. But then you could consider quadratus lumborum blocks. If it's a high insertion, you might also combine it with a subcostal tap block in addition. But it always depends on the incision. And if it's a medial incision, we have very good success by putting catheters in the rectus sheath. So this is also a nice block that should not be forgotten completely.
Okay, I can see there are some questions on the board. The first one is, when performing peripheral nerve block, where is the tip of the needle is placed, intraneural or intra or extra epineurium?
There was a time where some colleagues advocated to put the needle through the epineurium, and at least in some nerves that seemed to be not so dangerous as we thought. But I think in the community, everybody would rather avoid puncturing the epineurium and putting the needle as close to the nerve as possible. The sciatic nerve is a good example because this is a nerve that has a very robust connective tissue sheet. So you have to pass the connective tissue sheet surrounding the nerve, but you should try still to stay outside of the epineurium. If accidentally it should happen that we inject within a nerve, there are many studies that show that it's not as dangerous as we thought. But when I see that my nerve is swelling, that I'm within the nerve, I would always withdraw the needle and continue my injection outside of the epineurium.
Okay, the next one. When we combine multiple blocks, is it safe to exceed maximum dose limit of local anesthetics?
Tricky question. It is not safe, but sometimes when you have to use multiple blocks, you need quite some volume, and you will at least get very close to the maximum limits. I know many colleagues, they would exceed it a little bit, but of course the reabsorption will be on those different locations, and we will get high plasma levels at the end, and the chance for systemic side effects will be there. So even though doing multiple blocks, I would try to stay within the limits. Even though there is no good evidence, and in many recommendations, they do not even separate between different nerve block locations. It is a difference if you inject in an area that is surrounded by fat tissue while injecting into a plane that is surrounded by highly vascularized muscles.
And do you have any idea about the dose limit of local anesthetic on skinny patients and obese patients? Do you treat them differently?
No, I usually go by kilogram body weight.
Okay.
But it is also, if you check the different countries, the recommendations might be quite different in China and Norway, and it's not really good evidence. Why does the authorities state 4 milligrams per kilo here, and it might be more in another country? So it's after good consideration, but it's not like that there are very good studies that would support these recommendations.
Okay, what's the limit dose of ropivacaine in your idea? 4?
I think it's 4 milligrams.
Okay. Yeah, kilo. I think the same. Yeah, and I think maybe this time is the last question. Tell us about anticoagulant and the regional block. What's your idea about anticoagulation in regional anesthesia?
When using ultrasound for superficial blocks, I think you can be quite liberal. When it comes to deep blocks, especially lumbar plexus block or a parasacral sciatic nerve block, I would have the same precautions as for an epidural. I would never do a lumbar plexus instead of an epidural because of anticoagulation. And we know there are a lot of vessels. We don't have good control over the needles, and hematoma in the psoas muscles are a well-known complication. But of course, an axillary plexus block or a popliteal sciatic nerve block, I would do it in a patient with anticoagulation, but I always would try to balance the risk versus the benefits. When I'm having a patient that has a cardiac or pulmonary problem, I would be much more liberal than otherwise.
Yeah. And which test value would you think the most important when the patient is on coagulation? and scheduled for regional anesthesia via INR or APTT or else?
I would usually, it depends on the situation, but the ENR is the one that we usually use. But this gives in many anticoagulants a good measure, and of course the thrombocytes,
Okay,
the platelets would be
platelet. Okay. I think that's all the questions have been answered by Axel, and those are all good questions. And we're lucky that Axel gave us very, very perfect answers. And okay, I think today Dr. Axel Sauter gave us a very nice and fruitful lecture, and you also showed us your very innovative and inspiring invention of technologies in your work, and it inspires us a lot, and we so appreciate. And thank you, Dr. Axel Sauter. It's very good. Thank you.
Well, it was a pleasure to be with you and to join the webinar. Thank you very much, and I hope to see you all in person one day when the times have changed and when we're going to travel more again. And thank you to the audience for participating.
And thank you, Dr. Axel Sauter. Thank you so much for your very good lecture. And thank you, Dr. Shuai Tang. Thank you for your communication with Dr. Axel. And also, we thanks very much for our audience today who stay with us. And for more information about Wisonic new webinars, please follow up Wisonic public account on Facebook and LinkedIn. Thanks, and see you next week. Goodbye, Dr. Axel.
Bye-bye. Thank you.
Bye-bye. Bye-bye.
Yeah, bye-bye.